Hello, Gold participants and listeners from around the world. I'm Kristen Schwartz, licensed midwife and MC for Gold Learning. And here at Gold, our preparations for the upcoming Gold Midwifery Online Conference of 2020 are in full swing. And before the conference, we like to get together with some of our speakers and we chat with them, not only about the presentation, but also about what they are working on and what they're excited about in their field. And with me today is a speaker from our add-on package of perinatal nutrition, Dr. Teri Hernandez. Welcome, Dr. Hernandez.
Hi, Kristen. Thank you for having me.
It is wonderful to have you here. Thank you for coming.
Thanks for inviting me. I'm so excited.
So, Dr. Hernandez, you are the Associate Dean for Research and Scholarship in the College of Nursing and Associate Professor of Medicine and Nursing at the University of Colorado, and you are a cardiac nurse by trade. So tell us tell us a little bit about your professional journey. How did it all come to pass, where you are now, and tell us about your work.
Sure. Actually, a lot of people ask me that, Kristen. So I am a cardiac nurse by training, and I'm just trying to think of how to start this. And so essentially my really intense years when I spent much time at the bedside with very sick men and women with cardiovascular disease was in Dallas, Texas, in the 90s, believe it or not. So fast forward when I moved to Denver, basically it was a family move, and I started working at the University of Colorado, actually at University of Colorado Hospital. I started working in a research environment, and it was actually at that time that I was working with Dr. Robert Eckel, who is an internationally known endocrinologist, and so I began working with him, and he trained me in metabolism. So at that time I returned to graduate school, and incidentally at that time I had the privilege of working with pregnant women through our research studies. Some were with Bob Eckel. These were also studies with my who was to become my primary mentor, Dr. Linda Barber. And that's really when I started spending time with pregnant women. And these were very special pregnant women because they had gestational diabetes. And as a cardiac nurse, I had not spent time on the labor and delivery wards per se, other than in my training, my school training. And I began spending a lot of time with these women. And I was pregnant with them at one point, so as their nurse, they shared a lot of their anxieties with me and the things that they were very concerned about. And so I think all of us can appreciate, those of us who know about gestational diabetes know that, very often what happens with these women is that they go through about 2/3 of their pregnancy thinking that everything is normal.
Right,
and then
right.
Right. I'm glad that you're interjecting so I can hear you, Kristen. Yeah, and then they take the glucose tolerance test, and when they have the diagnosis, very suddenly to them, they have a high-risk diagnosis. They're given a glucometer. These are women who didn't have pre-existing diabetes, so they've not checked their blood sugar before. They have many more doctor's visits. They are essentially told, to limit dietary carbohydrate because of the risk for fetal macrosomia, which all of us know is one of the biggest risks with diabetes in pregnancy, and specifically gestational diabetes. And so all of this is very overwhelming in their lifestyle management and the things that they're told to do. And what impressed me, just talking with these women over and over, across many women in our Denver group here, they could handle all of the things that came with the diagnosis, except there was one thing they hated the most, and that was the quote-unquote GDM diet. The idea that they were told, to restrict dietary carbohydrate. And what I noticed our women here in Denver were doing was that they sort of reasoned within their own selves that if they don't eat carbohydrate at all, well, then that would prevent their baby from overgrowing. And so really what their eating pattern resembled to me was the way my cardiac patients were eating in the years when I was working on the cardiac wards. At that time in Dallas, Texas, the Atkins diet was the fad diet. And, many of my patients ate very high-fat diets and had poor eating patterns. And so fast forward, I couldn't understand. I was a graduate student at this time. I couldn't understand why, these special young women who we know are at risk for cardiovascular disease and diabetes. I couldn't understand why our advice to them about nutrition led to these kinds of eating patterns. And so that was actually in 2002, and I couldn't let the question go. And so I've actually dedicated my career to really trying to understand the influences of nutrition, particularly in gestational diabetes, but in all pregnancy, macronutrient mixtures, what actually gets across the placenta and how that imparts influence on fetal growth. And so essentially I'm sorry, that was somewhat a long explanation, but that's how I got involved in this field. So I'm very endeared to these women because of the stories that they told me.
Right. And I love how you made the connection. I mean, this is quite, I mean, it sounds almost like
Yeah.
to me you had to go that journey that you did because you experienced and the knowledge that you gained from your cardiac patients, and you took that and translated that and saw what's going on with your pregnant women there with gestational diabetes. I mean, that is something very unique. I think that puts you in a very unique position to find that connection and then work from there and get involved into the research and work with these women. That's absolutely fabulous.
Well, it was a great privilege. And, I think back to my days on the cardiac wards, and I think many of us can relate to this. At that time in the 90s, the link between diabetes and cardiovascular disease was not so
Right.
well understood. But in fact, almost all of my patients, I was injecting their sliding scale insulin, which of course nowadays sliding scale insulin is horrible, but that's what we had back then.
Right.
And it was really, I was really very fortunate to have mentors who were willing to, take me on, which again was atypical on a medical campus for a nurse to come in and want to do this kind of work, in very focused training and metabolism. So I was very fortunate that they believed in me.
Hmm. And also something else you mentioned, which really spoke to me, is like how you cared for these women when you heard their stories. You're absolutely right. It's a devastating thing for a pregnant woman goes through pregnancy. And as you said, by the time the glucose test is coming around, they're quite advanced in their pregnancy. They think everything is going fine. And all of a sudden they have that diagnosis. And, sometimes it feels, and these women nowadays, they are very, they do their own research, right, on the internet, or which
Exactly.
is great because there's a lot of good information out there, but also not so good information out there. And often, sometimes what we see here in our practice is that they tell us, look, if I go to that lab, the cutoff of the glucose gestational screen is
Right.
135, but the other is 140. So, but I'm at
Yeah.
138. I'm not, what, and they're kind of trying to figure this out. So this is hard. It's devastating for them because they've wondered, oh, did I do something wrong? What, I'm working out. What's going on here?
Exactly.
And then they also, of course, question then, of course, the validity of the test. So do you
Exactly.
usually also take then a hemoglobin A1C, or how would you go about in a case like where it's really kind of on the cusp, on the edge there?
Well, we here in Denver, okay, so Kristen, you've just articulated a huge issue in the field, and that
Yeah,
is that we don't have uniform diagnostic criteria internationally, which,
right.
is really, we're hoping to change that, in the coming years. But essentially, we still use the two-step Carpenter and Coustan method
Hmm,
adopted by the ADA. So, first they take the glucose challenge, and then they do a 3-hour follow-up with 100 grams
right.
of glucola, and we do use the A1C early in pregnancy.
Hmm.
So if they come in, we basically follow the ADA guideline,
Right.
but we don't use the international criteria here in Denver, at least at this point. So
Oh, interesting. Yeah.
yeah.
Okay. Yeah. And so just to let you know, I'm a midwife here in Florida, but I'm also out of hospital midwife. So for
Oh,
us
okay.
here in Florida, we, women with gestational diabetes, we have to risk out unless they can manage it with diet and exercise. And we have actually seen really wonderful, and I know that you will be speaking about this too, results with nutritional counseling, exercise, they're,
Absolutely.
measuring their blood sugar levels on a regular basis. They are, supervised by a neonatologist, so and who has to sign off then on the home birth or birth center birth. So there are some wonderful things that pregnant women can do, right?
Absolutely. And Kristen, I just want to reinforce what you're saying because nutrition is a very powerful force in pregnancy. It's a powerful force outside of pregnancy, but for sure in pregnancy, which I'll show everyone a little bit how we believe that works. Absolutely, we in the field have high hopes that we can come up with some real evidence-based nutrition guidelines so that really a majority of these women can be managed on nutrition alone
Right.
without the need for insulin and more expensive modalities with oral agents, which actually those carry some issues right now as well. Um, so I'm agreeing with you, but I want to acknowledge that
Yes.
that's tough.
Yeah.
This is very, very hard work. It's very rewarding work, but it's very hard work, and the the limitations within our health system really are causing us to try to just reimagine how it could be.
hmm
So
And
yeah.
absolutely. And speaking of diet too, you mentioned you couldn't understand how this particular diet is being used, which is still being used, for many
Oh
physicians.
yes, yes,
And and you made a very good point there. And sometimes you see also women who were told to go on this diet and they're not doing well. They feel like
exactly.
they can't handle it. They feel dizzy. They get all kinds of different health issues or concerns that they are not feeling themselves. And then, of course, they're questioning, oh my gosh, I need to do the best for my baby. Why can't I do this? What's wrong with
Exactly.
me? I mean, this is a whole also brings on a lot of emotional issues, right?
There is a psychology of gestational diabetes. And I've actually tried to start writing about it, but fortunately there are a number of social scientists addressing this. Really, I would say that the literature right now is very descriptive at this point, but the theme is very clear, and it's exactly as you articulated, Kristen. I mean, they're very anxious. Often they're depressed, and it does come down to that. They feel guilty because they're really trying to do the right things for their
Right.
baby. And often, really often, many of these women probably needed medication from the start, but of course
Mhm.
we don't always know that as providers. And so the fact that they do need medication can kind of be a symbol of failure when really it's not. I mean, and
Right.
it's really not a failure. It's just that they need some help. Um,
Absolutely.
and so, yeah, it's yeah, these are very special women. So,
Absolutely. And I can hear, when you're talking about this field and about the women, I can really hear the passion in your voice. This is really a topic, can hear that
yeah,
that is really dear to your heart. You've spent a lot of time
yeah.
researching, and not only researching and developing really methods of care here for these women, but you deeply care for these pregnant women. I can hear
You,
that.
I just want, if you don't mind if I just make a comment. These women who've been in our studies, I mean, I started doing this work, well, the first woman was enrolled probably in 2007. They were so invested. They have been so invested in our work over the years, especially those early women. They actually helped Lynn Barber and I design our studies and design the nutrition interventions so that women after them could follow them easier.
Wow, that's
So I mean,
awesome.
like they really wanted to pay it forward, and that's why they joined this work because they were so committed to trying to make a better future for women that would come after them. And it's something I'll never forget, and I always want to acknowledge that this is a team, and they've been part of our team.
Beautiful. That was beautiful thank you for bringing that up.
Yeah,
Um, Now let's talk a little bit about your
yeah,
presentation. Of course, you don't want to get too much away because we want our
of
listeners to
course,
come,
yeah.
of course, yeah. But just give us a little overview of what you hope our delegates will take away from this.
So you know what? My biggest hope for the outcome, for an outcome from my presentation is that all of your delegates rather will leave the presentation with an appreciation that the things we do for women with gestational diabetes, particularly in terms of nutrition, really apply to all pregnancy. I mean, that all pregnant women can benefit from good balanced nutrition. Now, that's not like a new message, but I'm going to show some data that hopefully will really um, help reinforce why that statement is true. Because we have been, the kind of research that we do is, we call it deep phenotyping data. But we do very controlled studies in pregnancy where we try to take out as many of the confounders as we can, which by the way is impossible. But I think so we won't we can't study 1,000 women, but we'll study 60 to 100 really well. And so what we think that reveals is a glimpse at really phenotype, itself, and, the isolated impact of nutrition, so that, in our kind of more controlled model, it gives us an idea of how it might react with the free living environment. So that would be my hope. And so I'll show some real, living lessons from our data, to help reinforce that point.
Wonderful. Now, I can't wait for your presentation. That sounds fantastic, and I'm sure we're all going to learn so much.
I'm excited too. So.
Yeah, thank you so much, Dr. Teri Hernandez, for sitting down here and speaking with me a little bit about your background. Very fascinating, very interesting, and also about the presentation. Thank you so much for your time here.
Thank you, Kristen.
And now for our listeners, this presentation, Primers for Nutritional Counseling in Pregnancy, Lessons from Gestational Diabetes, is part of the perinatal nutrition add-on package that we have here at Gold. To find out more about this presentation and the other presentation in the lecture pack, please visit goldlearning.com, and you can also find out more information at goldmidwifery.com. So we hope to see you all there, and thank you everyone for participating here with us today. Bye bye for now.